you've already watched the shoulder anatomy video, and now we're going to be talking about rotator cuff pathology. Along with rotator cuff pathology comes not only tears of the rotator cuff, but injuries and tears of the biceps, impingement from the acromion, which lives above the rotator cuff itself, and AC arthritis. So you may have any of these issues, and we need to treat them conservatively if possible, and that includes the physical therapy to try and strengthen the scapula, hold the shoulders back, and open the shoulder so you don't pinch as much, that impingement that we talk about. But if that fails, and if you're not able to get the pain under control with the therapy and the injections, we sometimes need to progress to the rotator cuff surgery. Depending on what size tear you have, we repair it. In addition to repairing the rotator cuff, we want to remove any offending agent that can pinch on the rotator cuff. The acromion is a spur that comes down close to the ball, and what it does is it rubs on the rotator cuff. It causes a decrease in the blood supply with time and eventually leads to tears. This is usually reproducible. As you turn mid-40s, you start to get some bursitis. That is inflammation on top of the rotator cuff as it rubs against the acromion. As that progresses, you get a partial rotator cuff tear, late 40s. Mid-50s, you start getting full-thickness rotator cuff tears. It is more common for you to get a rotator cuff tear with heavy lifters, with a lot of overhead activities, or repetitive stress injuries at occupational sites. If you do have a rotator cuff tear, you do not always need surgery. It really depends how well compensated you are. That's why we will always start with physical therapy. Physical therapy will strengthen the shoulder to hold the shoulders back, and then strengthen the internal and external rotators so that you're strengthening the muscles so that they pull the head down so that the deltoid doesn't over-pull and go up and pinch into that acromion. The biceps also is right near where the rotator cuff is, so that oftentimes gets included with the pinching and the tearing in the shoulder. Because of that, we sometimes have to, if conservative measures fail, including injections and the therapy, we sometimes have to do rotator cuff surgery. And the reason I grouped all of these together is that they all do come together with the same anatomic problems. And so if you're watching this, we're talking about a rotator cuff surgery. So we do multiple portals through the shoulder. It is not open, it's arthroscopic. Through that, we go in and we clean up everything inside the shoulder, whether it be a labrum that's torn or a biceps that's torn. We prefer to save the biceps. Some people will release the biceps and let it hang down to the arm. I prefer to repair it. I think that you improve your flexion strength and your supination strength, so I do think it's worthwhile to repair that biceps. In addition to that, we would burr down the tuberosity. That's where the rotator cuff inserts into. We do that to create a bleeding bed on which to reinsert the rotator cuff into. We then go up top and we shave off the bone spur because we don't want you to recur with a rotator cuff tear. So we're trying to decrease the anatomic issue that has caused your rotator cuff tear in the past. Oftentimes with active people, with heavy overhead laborers or weightlifters, you sometimes cause arthritis in the AC joint, and that can be a significant precipitator of pain for you. So if that is the case, and we can find out with that with a targeted injection into the AC joint, but if you can't tolerate it, we would go in and resect the AC joint through an arthroscopic approach. And the rotator cuff will be repaired. Usually I do a transosseous technique. I have a device that goes in, I drill a hole down into the tuberosity, I'm able to drill a metal piece into that loop, and then we feed sutures through the bone. And then that goes through the rotator cuff and it securely affixes it into the right position. Post-operatively is an issue for you. Number one, we worry about pain control. And you'll see this in the pain control video, what we do for that. The issue with the shoulder, however, is you do have to be in a sling from anywhere from 3 to 6 weeks. And it really depends on how big or tenuous your rotator cuff tear was. You can come out of it immediately post-operatively, and you can dangle your arm out and do pendulum exercises. You can also do exercises with your shoulder, with your elbow a little bit, but we really don't want you doing anything more than that. You will get a block in the surgical procedure unless you don't want one, but the block is beneficial because it decreases your narcotic requirements, makes you more comfortable at home. One of the hardest things for you after rotator cuff surgery is going to be sleeping. When you lay down, the shoulder rides high and it rubs against that surgical area where we did the debridement of the spur. Because of that, we prefer you to sleep in a recliner or with pillows behind your head with a pillow behind the sling so that it doesn't pull on you. So I hope that explains everything for you. Please feel free to ask me questions at the Surgical Center if you have any issues that you're concerned about, and we'll see you in the OR soon.